Good afternoon, everyone. I'm Dr. SHADMA from RIO Patna and will present a case on ocular manifestation of rickettsia. There's no financial interest, there's no conflict of interest. A 16-year-old male who came with complaint of diminution of vision in right eye since 5 days with preceding history of fever. There was no history of joint pain. The right eye ocular examination shows best corrected visual acuity 1/16 right eye, 6/6 in the left eye. Conjunctiva and cornea was clear. Cells 1+ present in the right eye and 2+ present in the left eye. Fundus examination, right eye normal discs with superior temporal and inferior temporal vascular sheathing and exudates with macular edema and hemorrhages around the macula. In the left eye, show the pale disc and superior temporal vascular sheathing and hemorrhages in the superior temporal quadrant along with the retinitis lesion. Investigations were within normal limit. We suspected this as a case of epidemic retinitis and carried on a dengue serology test which came out to be negative. But we carried on the wheel Felix test which showed the positive titers for typhus group and spotted fever group of rickettsia. Fundus fluorescent angiography was done which showed the vascular leakage and disc leakage which was suggestive of vasculitis in right eye as well as left eye. This is OCT of right eye showing the subretinal fluid and in left eye showing full thickness retinitis lesion. This is OCT showing vitreous cells in the vitreous which is suggestive of vitritis. We started the patient on tablet doxycycline 100 mg BD for 1 week, then OD for 2 weeks along with tablet omnacotil and topical steroid with topical midriatic. On subsequent visit, vision improved to 6/36 in right eye and 6/6 in left eye. This is a follow-up fundus image of the patient, right eye, which showed the resolving hemorrhages, resolving sheathing and decreasing macular edema. And the left eye showing resolving retinitis lesion and resolved hemorrhage. This is 1 month follow-up OCT showing resolving subretinal fluid in the right eye and resolving retinitis lesion in the left eye. 3 major categories of rickettsial agents, the spotted fever group, the typhus group and the scrub typhus. This is endemic in many states of India like Rajasthan, West Bengal, J&K, Kerala. The systemic involvement is characterized by triad as high fever, rash and general malaise associated with headache. The ocular findings of rickettsia is conjunctivitis, keratitis, uveitis, retinovascular changes, retinitis as well as optic nerve involvement. The vasculitis is the basic pathogenic mechanism and the deposition of immune complexes and inflammatory cells in the retina which will lead to the formation of white infiltrates. A suspected clinical case showing titers of 1:80 or above in OX2, 19 and OXK antigens by wheel Felix test and optical density greater than 0.5 for IgM by ELISA is considered positive for typhus group and spotted fever group of rickettsia. And the gold standard tests are immunoperoxidase assay and IFA. The treatment is, early treatment is critical to outcome and must be started on the basis of clinical diagnosis. The doxycycline is the drug of choice, whereas when doxycycline is contraindicated, azithromycin and clarithromycin can be used. Systemic steroids is used for in cases of extensive retinitis, serous RD, macular edema, retinal vascular occlusion and optic neuropathy. So to conclude, the clinical clues to diagnose ocular rickettsiosis is multifocal retinitis predominantly involving the posterior pole. Systemic fundus examination should be a part of the routine evaluation of any patient who presents with fever or skin rash living in or returning from a specific endemic area. Thank you.